All right, it's noon, so we are going to go ahead and get started. Thank you everyone for joining us for today's Spring into Health event. My name is Haven Spanier and I'm the Senior Director of Programming here at the U of SC Alumni Association. And it's my pleasure to get to introduce our host today. But before we get started with that, I want to give a huge thank you to Prisma Health for making this event possible today. And I want to let you all know that we want this to be an interactive event. So any questions you have, please type those either into the chat or into the Q&A. If you're not super familiar with Zoom, there should be a little control panel across the bottom of your screen with a chat button and a Q&A button. Either one of those will work if you type your questions into there, and we will get to as many of those as we can today. But without further ado, I'd like to introduce our host today. Creighton Edward Likes III, MD, received his medical degree from the Medical University of South Carolina in Charleston. He completed his residency in gynecology at Greenville Health System and a fellowship in reproductive endocrinology and infertility at Duke University Medical Center. He's board certified by the American Board of Obstetrics and Gynecology in both OBGYN and reproductive endocrinology and infertility. So thank you so much for joining us today, Dr. Likes. We're really excited to hear from you.
Absolutely. Thank you, Haven. And I appreciate everybody who's able to attend. Hopefully we'll have a few more. I know there was more that registered. They'll probably come in. I'm going to go ahead and share my screen with you as I start. But I do appreciate the introduction. I appreciate the time that y'all are taking out of your day and for having me. Just a little bit more background on myself. I am originally from South Carolina, born and raised. And while I didn't attend South Carolina undergrad, I did have a graduate school stint there. I have a master's in genetics and genetic counseling from the University of South Carolina. So I do have some Gamecock ties, and my wife was born and raised in Columbia, went to South Carolina, so further Gamecock. So if it's not basketball, I'll say go Gamecocks. Otherwise, it's Duke basketball for me. So saying that, I've been back from Duke, from fellowship back here at Prisma in Greenville for almost 11 years now. And I am the medical director here at the Fertility Center of the Carolinas under the Prisma umbrella. And again, very happy to be with y'all today. I will start out by saying this is, I usually have a very informal kind of approach, but also an educational approach because I want y'all to be engaged. Most likely I'll spend about 40 minutes maybe. I don't want to bore you with too long. TED Talks typically tell you not to take too long, but this will probably be about 40 minutes, and then I'll open it up to questions. So as I go, you can type your questions, but I'll probably address those at the end of the talk, if that's all right. So having said that, without further ado, let me get started. So we're going to talk about fertility as we age. And I have this conversation almost daily, multiple times almost daily, and hopefully you're going to learn a lot as we go. My objectives for today, my screen's going to work. Well, Haven, there we go. My objectives are going to be fourfold. So understand the overall rates, and you'll see what I mean by that when I talk about overall rates and when I get down to the perspective on numbers. Some of this may be a little eye-opening. I'm going to admit that to some folks because it's a little eye-opening. But again, I want it to be informative and educational for you because I want to equip you with the information that I think you need to know if you're considering going down the road of fertility and you're considering getting some testing and getting your options out there for you. Another objective is to learn that timing really is everything. I tell patients often that timing is important, not only from an age standpoint, from time of age, but also timing of within each individual person in terms of their cycle and trying to get pregnant. And we'll talk more on that in terms of timing. Again, perspective on the numbers. I'm a very big perspective guy. Kind of look at it from forest for the trees. I'll give you the numbers that I think you need to know that are very important from a fertility aspect and certainly in light of as we age. And then lastly, we'll talk about options moving forward. Once we do the evaluation, do the testing, what are your options? And they're multiple. And so you have to choose what's right for you. And hopefully I'll be able to equip you with that as well. So I said perspective. I like perspective because I think it puts us in the right frame of mind. I found this quote many years ago. You can see it's not almost 20 years old now, but I've used this quote multiple times in multiple presentations I've given. And it says, when human reproduction is examined in terms of efficacy, it becomes clear that the growth in population has occurred in spite rather than as a result of our reproductive performance. I know I don't want to be Debbie Downer with that, but that's, again, one of those eye-opening things, in spite of, as opposed to as a result of our reproductive performance. You'll see through this talk that the percentages may not be as high as you think from a naturally conceiving number and rate. Furthermore, for perspective, so patients oftentimes ask me percentages, they ask me chances of pregnancy based on their evaluation and so forth. And this is another chart that, or kind of an iceberg diagram that I've gone back to many, many times. Again, it's almost 20 years old, but it still holds true today. Well, actually, when I was in graduate school in South Carolina, I'll never forget, a professor told me 75% of all fertilized human eggs don't go on to make a baby. Let me say that again. 75% of fertilized eggs don't go on to make a baby. So that's this iceberg graph right here. The top portion, that little point at the top are the live births, and it's typically 25 to 30%. It says 30 on here, but 25 to 30%. So everything below that, unfortunately, don't continue to be a live birth, and that's where that 70 to 75% number comes in. And as we go through this process, you'll probably see why that is. And again, I think that's a little alarming to some folks, and it certainly was to me when I first heard it over 20 years ago in training. So numbers. So I know this is a very busy slide, and let me walk you through it, but I think it illustrates a lot of good points that will be the theme for the talk. And I'll start with the left graph, or the left picture there. Infertility is a lot more common than a lot of people think. You hear of 1 in 8, perhaps. So 1 in 8 couples, or over 7 million folks, have difficulty conceiving in this country alone. That equates to over 50 to 80 million worldwide. But you hear the number 1 in 8. Each spring, actually, there's a week dedicated to infertility awareness, and they have the 1 in 8 movement. They have t-shirts. They have a lot of awareness for infertility, but 1 in 8 couples struggle with this. What does it mean to have that diagnosis, or how do you get to that diagnosis? So right under that 1 in 8, you see over 35 and under 35. Now, this is based on maternal age, so the female's age. So if you're 35 years or older as a female, you can try naturally to conceive for 6 months. And if you haven't conceived by then you're deemed potential to have fertility issues, and you need to be evaluated. Whereas if you're under 35 years old, you can give it 12 months of naturally trying to conceive. And if it hasn't happened, then you need an evaluation. That's kind of what the books say. However, if you go down to that last thing on that left side picture, it says 91% of folks wish they had started their fertility journey earlier or sooner and not waited that either 12 months or 6 months. So my point is to say this, that's the diagnostic criteria. However, I tell patients all the time, it may be worth your while and very logical to get an evaluation sooner, especially if you know something else is going on. Get that sooner and don't necessarily have to wait that time, and hopefully regret won't be part of your decision making. Moving to the right picture, again, it says the same thing about 35 or younger or older, but I want to go to the time to conceive. If you see that bar graph, couples trying for 12 months, 85% of the time, they're going to have a spontaneous conception. They're going to get pregnant on their own, 85%, but that still leaves, after 12 months, 15, maybe 20% of folks or couples still not able to conceive. And then that line graph with fertility by age, it's really the reason. And we're going to get into this in more detail as we go, but this is the main reason that those numbers are what they are and why we hasten the evaluation based on age. So that fertility by age graph that you see there, unfortunately, it declines, obviously, as we age. And again, I'm going to get more specifics with those numbers. The last thing is just kind of funny. The celebrities are thrown on there. Not funny to say that it's not true. It's funny because they are actually bringing this more to light, and that's excellent. And so you probably see a lot on the media with celebrities such as the ones listed here or others of the struggles that they've gone through and the treatment that they've gone through. It's actually brought to light a lot of, or a lot of awareness, and also less angst and less maybe reserve in terms of finding out and moving forward with evaluation. So it's a wonderful thing that they're doing, I think. So timing, I've already mentioned that I think timing is important. And by that, what I mean is age. Age is a mechanism of time, as we all know it. So as time goes by, as we get older, we've just illustrated that it can get more difficult to conceive. And so age is going to be an overarching factor. And then those other three, your cycles, ovulation, and intercourse, that all has to do with timing as well. And so the cycles that we're going to talk about, obviously, are the menstrual cycles. And ovulation. Is a woman ovulating every month? If she is, when is she ovulating? And how is she tracking that? And is it accurate? And then intercourse. I'm going to go through the mechanisms in terms of timing that's important based on the cycles and ovulation for intercourse in order to try to optimize conceiving each month. All right, take a step back. This is Physiology or Biology 101. I am not going to hold you to recognize or memorize this graph. I only throw it in there to show the intricacies of what has to go on for a proper menstrual cycle, ovulation, and potential conception to happen. All that you see on that one graph has to go on every month to try to optimize what's going on and try to optimize conception. So for instance, those hormones that you see listed, the FSH, the estrogen, LH, progesterone, they have to come from the brain, the pituitary, signal the ovary has to do the right thing in the right time, the uterine lining has to do the right thing in the right time to be receptive for pregnancy. All this has to be timed. And so you can imagine if anything is just a simple kind of delay or hastening, then they can skew the numbers and the percentages may not be where you want them to be in terms of conceiving. So just keep that in mind, that there's a lot of synchrony and a lot of things that have to go just so for everything to work right. And so timing of tracking cycles, you see in the books, you probably hear online, you hear it everywhere, 28 days. That's what everybody says the cycle is supposed to be. Well, that's not accurate. 28 days is kind of the average, but I will tell you, hardly any of my patients have an exact 28-day cycle. So that can actually be 5 to 7 days later or 5 to 7 days earlier and still have a quote normal cycle, just it's dependent on your cycle. So meaning 35 days could be normal or even 22 days could be normal. So tracking cycles is one way to start learning what your body's doing. And then the OPK and BBT, we have a lot of abbreviations in what we do. OPK is ovulation predictor kits and BBT is basal body temperature. This is another way that women try to track their cycles and when they're ovulating. And I will tell you the basal body temperature is very difficult. I don't know if anyone out there has done it, but it's supposed to be take your temperature right when you wake up. Well, any movement can cause your temperature to increase. I actually just had this conversation with a patient this morning. So it can be very difficult. Ovulation kits, about 15 to 20% of the time, they can be false positive. And so I still think they can be a usable tool, but just know that they do have some limitations. Any changes in timing, meaning over the last X amount of months or years, have you noticed that your cycle timing has changed? Was it once 35 days and now it's 26 days? Those sorts of things may throw up a red flag for your doctor to evaluate further to say, is there anything else going on that could cause a problem with fertility? And then I mentioned timing of intercourse. So this is one pearl I'll give you. The timing of intercourse is very important. The optimal time to conceive is 48 hours prior to up to the day you ovulate. If you haven't had intercourse in that time frame and you wait till after you ovulate, the chances of pregnancy are exceedingly low. So that's why I keep going back to tracking your cycles, knowing maybe when you ovulate to try to time that intercourse, because it's that 48-hour window, maybe a little bit more, but that's the optimal time, 48 hours prior to up to the day of ovulation. So other factors from a timing standpoint, obviously we're talking about the age again and what can come along as we age. So weight change, and I don't mean just obesity, I mean weight change from too thin to obesity as well. BMI, body mass index. So we have a quote sweet spot for body mass index for fertility. It's usually about 18 to 19 to about 25, 26, so 19 to 26. That's not to say those folks on the extremes of that cannot conceive. I am simply saying they may have some subfertility based on their weight for various reasons, but there is a proper weight spot that we're looking for in regard to BMI. The next 2 bullet points, smoking and alcohol use. Obviously, that can change as we age. And unfortunately, vices are very common. And both of those, if they're used in excess, certainly can affect both male and female fertility chances from an egg quality standpoint, ovulatory standpoint, and sperm quality standpoint. So keep an eye on that, and certainly cessation would be the best thing. Medical issues. Again, as we age, unfortunately, we can develop medical problems. So, for instance, I mentioned obesity, high blood pressure, diabetes. These sorts of things can also affect fertility. And so, obviously, being in optimal health is going to be the right path. It's easy to say, sometimes very difficult to do. Suffice to say, we want you as healthy as possible, not only to try to conceive, but also for the pregnancy itself. Medications. So, some medications that are associated with those medical issues I talked about can affect fertility. Not only that, some medications you can't take when you're pregnant. So we're going to go through a list of those when we see you for an evaluation and say, yes, we need to change this, or no, this is fine. And then family history. Certain things that we'll ask about are there any recurrent miscarriages, folks who've had multiple miscarriages in the family? Blood clots, DVTs. Are there any folks that have DVTs? Because that can affect potential fertility. Anybody in the family that's gone through menopause early, that's certainly also a red flag for some women that we see in terms of their family history and testing. And so these things we take into account. And again, they can be factors that can affect fertility as we age. So what are the numbers? So the biggest thing, and it's an unfortunate thing, but the biggest thing is there's a difference between males and females when you're talking about age-related fertility issues. The reason is this: women are born with all the eggs they're ever going to have. And so as they go through their lifespan and go through cycles, they're losing eggs continuously. Whereas men will typically produce sperm well into their older years. And so when I talk about age-related issues with fertility, unfortunately, women see that earlier in life. And that's why when we get to these next slides, you'll see what I mean. And that's why it's more focused on women, quite honestly, because of this egg number scenario. So we'll start with the male side of things. And what can cause, obviously, male factor issues, male factor infertility? Well, we've kind of already addressed, addressed the left side in terms of risk factors, the medications or drugs, alcohol use, smoking, and weight. All those can affect sperm production, sperm quality, and so forth. Tight-fitting clothes, sauna use, truck drivers that are seated for a long time and produce heat, bicyclists, those sorts of things can also be risk factors for male infertility. And so it's kind of the old saying, everything in moderation in that regard. And then the right side is the breakdown of other causes for male infertility. And you'll see, unfortunately, over a third are unexplained. And so we can do a semen analysis. We can see that there is male factor, but a third of the time, we're not going to be able to give an answer why. And that's difficult. But other than that, some of these can be corrected. Obviously, an infection can be corrected. A varicocele, which is actually a blockage, that can be surgically corrected by a urologist and may improve the numbers. And then there's one thing on here that's interesting that's probably falls under other causes is genetic. It sounds a little silly, but there can be genetic infertility causes. One of those that I'll get to later is actually cystic fibrosis. If males are carriers of a cystic fibrosis mutation, they can actually have significant fertility issues. And again, I'll touch on that later. What not to do, despite what TV tells you. So we have all seen the ads. Low T, here's some testosterone, let's take it. You can see this is an ad in Oregon. The benefits of testosterone replacement therapy. They list before and after a number of issues. Obviously, fatigue, are you depressed, muscle, those sort of libido, those sorts of things. Well, easy fix. Let's just take a shot or a pellet or whatever of testosterone. Here's the problem. While that may be good for folks who are not trying to conceive, to try to remedy those symptoms, if a male is trying to conceive, taking testosterone is going to potentially drastically decrease his sperm production. The reason is this: if a man is taking testosterone, basically what that does is it shuts down those signals from the brain to the testicles to make testosterone and sperm. And so you're not making sperm. I had 2 patients in 1 week who had 0 sperm on their semen analysis because lo and behold, they were taking testosterone and their doctor didn't say anything and they didn't know about it either. So the good news to this is usually we'll have them stop taking the testosterone and then repeat their analysis weeks later, and typically they'll have sperm production again. So it is reversible, but you hear this a lot. Low T, take some testosterone, but not in men trying to conceive. Okay, so let's shift gears to the female side of things. So what are the female factors? And I have already alluded to egg number. And so we have a term called ovarian reserve. That means egg number. This graph illustrates that perfectly. So on the left, or the y-axis, are how many hundreds of thousands of eggs that the female ovaries can hold. And then as we age on the X, it shows that that line goes down. Interestingly, women actually have the most amount of eggs in their ovaries that they're ever going to have when they're in their mother's womb. So the fastest rate of decline is actually from before birth to birth. So you can see by this chart, we'll say 0 is birth, hundreds of thousands of eggs are present in the ovaries. However, by the time puberty hits around 12 to 16, whenever it is, there's that hundreds of thousands have been lost. And then from that point, and this graph goes to 51 because 51 is the average age of menopause in this country. From that puberty to age 51, you see this decline in eggs. What's interesting is each month, a woman is recruiting hundreds of eggs. And so a lot of folks don't realize that. So you're actually recruiting hundreds of eggs, but by that hormonal control that I mentioned or illustrated in that picture, typically you're only ovulating 1 egg each month. That's how humans kind of intrinsically decrease the chance of multiples, but you've used up hundreds. And so that's why there's this decline from about 300,000 eggs to less than 1,000 in a matter of 30 years or so. And so that's an important point to realize that each month, hundreds of eggs are being recruited and used, but only 1 is typically ovulating. To take that further, these 3 pictures or graphs kind of illustrate what I've alluded to in the past or earlier in terms of natural conception rate. So that first image, I apologize, it's a little small, but how your age affects normal conception. So background, again, perspective. If everything's perfect and we're less than, let's say, 30, we only have about a 20 to 25% chance of getting pregnant each month. That's it. That's why that left bar graph is up to 25%. But you can see a steady decline as we age. And so the middle picture kind of delineates it perfectly. At 30, we have about a 20% chance, like we talked about, women's age of 30. But at 40, a healthy 40-year-old woman only has about a 5% chance of conceiving naturally. So this is natural rates, not any intervention from what I do. And then the third graph on the right really illustrates another point that makes it a little bit more complicated as well and a little bit more difficult. What you see is the blue line is kind of what we just talked about, the natural rate of fertility and how it declines with age. The orange line, however, is what's called the miscarriage rate. And so those are inversely related, meaning not only is it more difficult to get pregnant as we age, unfortunately, if you do conceive, the miscarriage rate drastically increases. And so at, say, 35 on that chart, your miscarriage rate is probably on the order of 25 to 30%. But then at 40, your miscarriage rate is on the order of 40 to 50%. And then should a woman conceive naturally at age 44, 45, her miscarriage rate is going to be on the order of 80 to 90%. And so that is another kind of level to all of this that makes it a little bit more difficult to have a child as we age. And the vast majority of miscarriages are due to what's called a spontaneous chromosome abnormality, meaning it's nothing that the woman or man did. It's just, unfortunately, when the embryo came to develop, there was an abnormal number of chromosomes, and that typically will lead to a miscarriage rate. That's why that miscarriage rate increases with age. The next slide is going to also describe that same thing. So you hear this proverbial biologic clock. Well, we've already talked about time, egg number, but what about egg quality? And so that's what is alluding to the chromosome issues that can occur and can increase in probability of miscarriage as we age. This graph on the left is showing the average percent of eggs with normal DNA or normal chromosome makeup. And so again, you see as the younger age women, they have a really high percentage of eggs with normal DNA. Unfortunately, though, as age goes along, that percentage dwindles. And so we know this through our studies with IVF or in vitro fertilization, because we can now test embryos and eggs, for that matter, for their chromosome makeup. So this is how we know these numbers. And so at 40, the chance of having a chromosomally normal egg is only about 40%. So 60% of the time it's going to be chromosomally abnormal and potentially or will increase the rate of miscarriage. That picture on the right of the screen, talk about egg and sperm freezing. That's a topic I'm going to really get into towards the end of the talk, but this is a way to try to kind of thwart this quality issue in terms of the chromosome issue, and I'll explain that in a little while. So learning more. So again, through our studies in IVF and through these numbers we just talked about, if we're talking about not only eggs, but now we're talking about embryos. So embryos are fertilized eggs, right? So a sperm has fertilized an egg and it's created an embryo that could potentially create a pregnancy. Well, that left chart is showing, again, the age breakdown and then the percent of genetically abnormal embryos. So that number is going to increase as we age because the chance of a chromosome abnormality is certainly going to increase. And again, that's going to lead to the potential for miscarriage. That chart on the right is showing the chance of a chromosomally abnormal live birth. So I know I have stated that a majority of miscarriages are chromosomally abnormal. However, not all chromosomally abnormal embryos will miscarry, and they can go to live births and have chromosome abnormalities. And those are the numbers that we have to quote patients if they were to conceive naturally or with some other means, that their rate is at 41 and 65 of having a chromosome abnormality in their child. And so these are just numbers that are important. They're not meant to frighten or scare. They're not meant to be a scare tactic. It's just knowledge, as I mentioned before, education and what we know and how we manage them, how you manage them as a patient, and then what we can do to try to optimize them, like I said, improve. So options moving forward. Obviously testing. Now, when I say testing, I'm talking about both men and women, and I'll get into that in great detail in the coming slides. And then treatment. We have a multitude of treatment options, and it really depends upon what the testing shows. Is it imperative that we start now as opposed to waiting? Or if the patient says, well, the testing is reassuring, I want to wait, what does that mean for them? And then thirdly, future options. If the patient or patients decide to postpone any kind of fertility, what are their options in that regard? So again, consider both sides. I always tell patients when I first meet them, what I don't want to do is put blinders on and say, I just need to focus on the female side because that's where the majority of the percentages are. It's not true. When I see a couple, 30% of the time, it can be a combination of male and female issues. So I don't want to miss or discredit testing both sides. So always keep that in mind because that will certainly potentially change our treatment and protocols as we go. So what is involved in the evaluation? Again, from both sides, male and female. Well, certainly a history. We're going to take a good history of both medical histories for them. Again, seeing if there are any medical conditions. We're also going to take a family history. Are there any familial things that we can pick up in terms of fertility-related issues? And then also important is, have they had or are they going to have any kind of chemotherapy, medicines or regimen or radiation? XRT stands for radiation. So previous cancer patients, Hodgkin's patients, for instance, who have had chemo in the past, that can unfortunately affect their fertility now. Or the flip side of that is if a patient has a newly diagnosed cancer diagnosis and they're going to need either chemo or radiation, that may affect the fertility in the future. So there's different routes we can go with that in terms of treatment. And I'll allude to that also later. Lab work. Well, this is blood work, and blood work is important initially from the female side in terms of the Ovarian Reserve and other things that I'll allude to. And then certainly lab work can be done based on the male semen analysis. Ultrasound. So in ultrasound, we do all the time here at our fertility clinic because we consider an ultrasound, and this is of the uterus and ovaries, we consider that an extension of the exam. It gives us a lot of information to help the patient. That AFC stands for antral follicle count. If I did an ultrasound of the ovaries, I can, and I have pictures of this, I can actually tell you if your follicle count, follicles are where the ovaries are, or excuse me, where the eggs are in the ovary, I can tell you if that's a normal number. And that's a good thing to know, because again, that'll help us guide the treatment. Certainly a physical exam, if anything's abnormal, a physical exam that is related to fertility. And then finally, from the male side, the semen analysis. And so I alluded to the cystic fibrosis testing, and let me go into that further. So evaluation, so what we do is, it's kind of like, I call it a snapshot of your fertility right now, knowing that this is just one kind of snapshot in time and it can change as we go forward, but what is it right now? So from the male side, it's a semen analysis. That's the initial first step that we will typically always do. And there are different values and parameters that we look for on a semen analysis. Some are listed there for you. Another one is called morphology, which is the shape of the sperm. We give it a grade. But we get those parameters and we say, okay, it's normal, or no, you have low motility or low concentration, low total number of sperm, those sorts of things. So I've already alluded to testosterone use can actually deplete sperm production. So we may see 0 sperm in a semen analysis on folks who are taking testosterone. But what if we see 0 sperm and they're not using any testosterone, or they don't have any blockage based on a urologic exam? Why is there 0 sperm? At that point, then we start thinking of genetic components. And I mentioned cystic fibrosis. So interestingly, cystic fibrosis carriers, right? So Caucasians actually are a 1 in 29 chance of having a cystic fibrosis mutation being a carrier. So if a male has a CF mutation and he is a carrier, meaning he doesn't have the disease, but he has the carrier status, he could have what's called absence of the vas deferens. And those are the tubes that allow the sperm to be in the analysis. If that's the case, he won't have any sperm in his analysis. We have found that as well. And you can imagine that is a repercussion for him for future children, because even though he doesn't have sperm in his analysis, we can still do IVF with sperm maybe aspirated from the testicle and create embryos with his DNA. But it's important to know, because if he's a cystic fibrosis carrier, he wants to know that for the risk of his children. So you can see how this path widens as we do these evaluations and what we go down in terms of the evaluation to give them the best information we can. Albeit rare, but again, 1 in 29 Caucasians are cystic fibrosis mutation carriers. So females, what's kind of their snapshot of fertility? What's their evaluation look like? Well, I mentioned labs, and AMH is another abbreviation that we use all the time. AMH is a lab value that gives us a very good marker of a woman's egg number. So that picture, that black and white grainy picture, that's actually an ovary on ultrasound. All those little black circles, those are what are called follicles. That's what I was alluding to, that I can count. 6 to 10, they're called antral follicles, or AFC. 6 to 10 is a normal number. So you can clearly see this ovary has plenty more than that. So AMH comes directly from cells in those follicles where the eggs are. So you can imagine this ovary is going to produce a lot of AMH. So in the blood, her AMH is going to be high. And I'm going to say to this patient, your egg number is high, it's good. Whereas if on the opposite side, if the egg number is low, the AMH is low. And so this is a very good measurement to say, okay, your AMH is reassuring. Okay, again, things can change, but right now your AMH is reassuring. A level to remember for an AMH is the level 1. It's very easy to remember 1. An AMH of 1 is about where a 40-year-old female should be. So if you were to get your AMH, you can kind of compare it to 1, and that's where a 40-year-old should be. Okay. A normal range of AMH, someone in their 20s and 30s, is only about 1.2 to 3.5 or 4. It's not a huge range. Just remember 1 to 4. But that's kind of a frame of reference that you can use. I mentioned the ultrasound for the follicle count, and I also put on there as a evaluation of possible HSG. So HSG stands for hysterosalpingogram. It's a fancy word for the dye test of the tubes. So the fallopian tubes, for a quick anatomy lesson, those are the tubes that are on the side of the uterus that allow the sperm and egg to meet. Well, you can imagine if the tubes are not open, I can give all the medicine in the world, but sperm and egg aren't going to meet and you're not going to conceive. HSG will tell us if the tubes are normal and if they're open. Risk factors for tubal disease are pelvic infection, pelvic surgery, history of an ectopic tubal pregnancy. If you've had those, again, based on your history that we take, then we're going to do this HSG earlier than later. So I just throw that in there as a possible another mechanism to give you information to say what you might need from a fertility standpoint. Okay, so options moving forward. There's basically three of them. Do you do the evaluation and y'all decide, or do they decide they want to be pregnant now? Or do they do the evaluation and say, well, I feel good with this, I want to wait, I'm not in any rush? Or do they do the evaluation and say, I want to wait, but I still want to preserve my future fertility? So these are patients who may be single, who may have not found that right person, or not in a state in their career or finances to have a child now. Or, like I mentioned before, folks who may be facing a cancer diagnosis and chemo that may completely deplete their fertility chances in the future. So those are the three options that we talk about moving forward based on those evaluations and based on those numbers that I've already discussed. So what does that look like? So let's say we do the evaluation and they decide, well, we want to go ahead and move forward with trying to conceive. Or they say we've tried for 6 months and it hasn't happened. So what we'll first do is make sure this evaluation on both sides, male and female, is complete. So has the semen analysis been done? If they've tried for X amount of months, have they tested their tubes by now to make sure that they're open? And then other lab work, like I mentioned, in ultrasounds. And then based on those evaluations, it's our duty to try to plan a protocol based on what the patient wants. And it's my theory in terms of how I practice medicine is, in my field, what I'm trying to do is give you as much information as I can and make recommendations based on those evaluations to give you an informed decision to make for yourself, because this is really steered by the patient. And so what I don't want to do is push them in a direction you don't want to go, but I also don't want to feel like they're spinning their wheels. And so once this evaluation is done, I have a number of protocols I can recommend based on the numbers. And it's kind of like, in terms of aggressiveness, I always equate this to steps of a ladder or rungs of a ladder. There are oral medicines, injectable medicines with the oral, all injectable, and then IVF. That's kind of how we go. That's mainly from the female side, from a medicine standpoint. If there is a male factor issue, that protocol may change with procedures. Meaning if the male factor issue is low numbers, we may say, okay, we're going to do an in-office insemination. Or if the numbers are significantly low for the male side, we may say we need to go straight to IVF because these numbers are too low. So that's how we work the evaluation into a protocol and recommendation. But again, it's the patient's decision ultimately, because it's what they want to do. And I certainly wouldn't force it on them, but I would give them the numbers appropriately. So the second option was, well, they do the evaluation and they want to wait. And that's perfectly fine. If they understand the information, and I've done my job in giving them the numbers and the percentages that we've already gone through, and they say, I'm fine, I want to wait, perfectly fine. We counsel them on the age-related issues, and we counsel them on the effects that come along with that from a fertility aspect. One point that I always make is those medicines I just described to you, and there's a number of them, they are not going to change the age-related rate. So whether you're 32 or 36, I can give you the same medicine, but unfortunately, you're going to have different miscarriage rates based solely on age. So the medicines are not going to change that. Okay, that's just set in stone, unfortunately. And that's an important point for patients to hear. And so we're almost to the last part here. So what if they say, okay, we have what we need, but we're not ready, but we certainly want to preserve our future fertility? Well, there are options, and it's obviously dependent upon if it's a single male or a single female, if they're facing the chemotherapy from cancer, or if they just want to preserve their fertility for the future. Or is it a couple and they may want to do what's called embryo freezing? And I'm going to get into these more specifically, but cryopreservation just means freezing. So sperm cryo is semen freeze, oocyte means egg, so that's egg freeze, and then embryo cryopreservation is embryo freeze. So these are the three options of, if you don't want to conceive right now, but you certainly want to maybe preserve that future fertility, this is what we can offer. So sperm cryopreservation or semen freeze is pretty straightforward. Just like a male would collect for a semen analysis to look at the numbers, it's the same exact process. But in this situation, what our andrologists in our lab would do, they would freeze the specimen. Now, typically, men will have millions of sperm per specimen. And so what we will do is we'll freeze them in different vials or different straws, whatever the case may be. And I tell them, okay, sir, you have this many vials with this many, hopefully million sperm in each vial. So in the future, should you want to use that, you can kind of consider one vial one attempt to conceive. I say that to patients because if they say, well, I only have 3 vials, I want a sperm bank, they can collect again and add to the vial number for future potential. So that's important to note. Now, when we use frozen sperm in the future, there are only 2 routes. There's the office insemination, and then there's IVF, in vitro, and that's going to be the highest success in this realm. But they just need to know that those are the 2 chances or options. They may not even need the frozen sperm. If they're doing this for maybe chemo and then the chemo doesn't affect their fertility, they may just have this frozen sperm for insurance sake. But that's how sperm freezing goes. So egg freezing, or oocyte cryopreservation. This has gained a lot of popularity recently. And I go back to the celebrities that we mentioned in the beginning. I have friends across the country who do what I do, and in different parts of the country, it's interesting. There are literally egg freezing parties. So young professionals. So why has egg freezing become more popular? Well, honestly, people are putting off childbearing for their education, advanced education, their career, and so forth, and they're trying to kind of suspend time, so to speak. And I'm going to get to that in my last slide. So they're trying to preserve that age-related issue, and so egg freezing has become more popular. And so egg freezing is a process where you see it there. And in terms of the consultation, we get the history like we've already talked about. But then what we're going to do is have the patient take medications to really ramp up production of eggs. So remember when I talked about the menstrual cycle, and each cycle you're actually recruiting hundreds of eggs potentially, but only releasing 1? Well, in these types of cycles, what we're doing is we're just accentuating that recruitment with the medicines we have. And so you're recruiting, hopefully, a lot of eggs. That picture on the right is actually another ovary, so similar to what you've already seen. And those black kind of circle areas are the follicles. That's where the eggs are. That bright white line at the top is actually an aspiration needle. And so this is an actual picture of an egg retrieval that we do routinely, where number 3 in the egg freezing process diagram, number 3 is the egg retrieval, where we do a vaginal ultrasound, and we have a needle that actually inserts into the ovary through the vaginal wall on either side to aspirate the eggs that way. And so you can see this over here has a number of eggs, and an average yield is actually 10 to 20 eggs. And so we're trying to preserve the fertility for this patient from egg freezing standpoint. So once the eggs are retrieved, and it's about a 20 to 25 minute process, then they're frozen. That day they're frozen, and the patient knows how many they have, and they're stored for years. And so that's kind of insurance for them. Again, depending on upon why they're doing this, they can use them later to create embryos to try to have a child. So that's egg freezing. The difference, egg versus embryo, is great. The process actually leading up to what I just talked about, the process of getting to the egg retrieval, it's identical. Whether or not you're doing egg freezing or embryo freezing, it's identical. We give the medicines, we retrieve the eggs, and at that point, that's when it changes. Because if they're trying to create embryos, that involves sperm. And so obviously, it doesn't always involve a couple. Sometimes single women will use donor sperm to create embryos to freeze. But an embryo is obviously a fertilized egg. Okay, so those bullet points, it's the same process as to what leads up to the egg retrieval. And then we have you see that picture, embryo cryopreservation. That's actually what we do in the lab. Our embryologist will actually take one sperm and inject it into the egg under the microscope to try to fertilize it. And so once the embryos are created, they're allowed to develop for a few days, and then we freeze them. And they can be frozen also for years to come to use in the future. So that's an important point, because there are some differences in egg versus embryo freezing. And that second bullet point says the thaw in the future. So let's say you've done this and you have either an egg or embryos frozen, and you're ready to use them 3 years down the road, 5 years down the road, whatever it is. The thaw rate, meaning from thawing to a successful either egg surviving the thaw or embryo, is different between the two. Embryos are almost a 1-to-1, meaning if you have an embryo frozen and you thaw it, it's going to survive the thaw, probably 97% of the time. But an egg is a little different. An egg is a little bit more or less hardy than an embryo, meaning it's not a 1-to-1 always. So typically I say 5 to 6 frozen eggs will usually equate to about 2 to 3 embryos. So that's important because going into this, we have to know that there's a difference in thaw. And so we may say to the patient, do you want to try to retrieve eggs again to ramp up the number or bank eggs for future? So the thaw rate is important in terms of egg versus embryo. The other thing I mentioned was it kind of suspends time, meaning the age-related issues may not apply. So this is another reason women are doing egg freezing, and a very logical reason is, let's say you're 33, 34, and you're not ready to have children, or you're single and working on your career. What they'll do is they say, well, I want to go ahead and freeze my eggs now, because if I'm not ready to conceive until I'm 38, and I just showed you those miscarriage rates and the decreased fertility rate, well, if you have eggs from a 34-year-old, it does not matter when you're 38 if you're using those eggs. Those age-related issues are going to be when they were frozen. And so that's why it can kind of suspend time, so to speak, in those numbers. The bullet point I have underneath the suspends time is it says PGT in embryos. So I told you that none of the medicines I have change this age-related issue in terms of miscarriage rate and other things. But PGT, which stands for pre-implantation genetic testing, actually can reduce the miscarriage rate associated with age. What PGT does is we create embryos, as I've already listed in terms of the process. And before they're frozen, our embryologists can biopsy a few cells of the embryo, and then we freeze it. The embryo at this point is hundreds of cells. So they only biopsy about 3 to 7 cells, but we can tell from those cells the chromosome makeup of the embryo. And so if I told you that the vast majority of miscarriages are chromosomally abnormal, well, then we know which embryos are chromosomally normal, and will decrease the miscarriage rate in that regard for a future transfer. So that's just another layer to all of this to try to get at this age-related issue, not only of fertility, but of miscarriage rate. And then lastly, ethical concerns. And so you can imagine my field is pretty ethically charged. And I have a saying that the science has far outpaced the ethics in what we do. And just because we can do it doesn't mean we need to do it. But I have a number of patients on the continuum of ethics and their ethical concerns of what we do. And so I say that because in egg versus embryo freezing, if people ethically believe life starts at fertilization, well, then they may choose to freeze eggs because it hasn't been fertilized. And so you have to go through these discussions with patients, and it opens up a big discussion, quite honestly, in terms of what they want and what their beliefs are. And so it's just something else that we think of when we're talking about doing these egg or embryo freezing. All right. So I said a lot. It's been longer than I expected, but a quick recap. I think I've explained that age and time play a role. And certainly it's not going to be illogical to do an evaluation sooner rather than later if you have any questions. And then based on that evaluation, we can plan accordingly together once you know your options and what you want to do for your future fertility in regard to nothing right now, or in regard to maybe getting ready to move forward, or thinking about future fertility and freezing. So with that, I will leave my contact information up. That's Fertility Center of the Carolinas. Again, we're mainly based in Greenville. We are actually opening a satellite office in Columbia in the Park Ridge area near Irmo. It's opening in a month or two, and it'll be a satellite office for us. That's our number. And then if you're on Instagram, I do a lot of Q&A on Instagram, and that's me and then our center. So with that, I will pause. And Haven, if you want to come back on, I'll address any questions maybe.
That looks like we have several questions in the Q&A, so I will go ahead and pull those up.
Okay.
The first one says, I went through fertility treatments at 28 years old to have my first, and again at 31 for my second.
Okay.
I'm 34 years old now, looking at what my chances of having another successful pregnancy in the next 2 years.
She's asking, what are the chances?
Correct.
I think it's going to depend on one, how, because she said she went through fertility treatment the first two. So what did that entail? First off, how aggressive was that? What were her evaluations then? And then quite honestly, I have patients come back to me for a second or third child, and what I tell them is, exactly what I just mentioned in terms of let's get an idea of where you stand now from an ovarian reserve standpoint and maybe an antral follicle count standpoint or the ultrasound. And then that'll help me tell you and equip you with maybe that answer. You're still hopefully in that percent that's going to greatly favor your success. And so I would get those evaluations again to say, well, here's where you stand. What did you do before? Do we need to increase that? Or do we just need to do the same thing because it was successful and nothing much has changed in regard to your evaluation?
All right, this next one, how do fibroids affect fertility?
Good question. So I didn't go into that, but it's another aspect of the fertility evaluation. And actually that does go back to the ultrasound, like I mentioned, as an extension of the exam. So for those of you who don't know, fibroids are basically balls of muscle. The uterus is a muscle and fibroids can grow world muscle anywhere in the uterus. And so I tell patients that fibroids are a lot like real estate. It's all about size and location. And so fibroids can definitely affect fertility. Obviously, if they're in the uterine cavity, that makes sense because it's a space occupying lesion where the pregnancy needs to be. But they can also affect them if they're large and in the muscle wall of the uterus. And so it would be justified to do an ultrasound to do what's called fibroid mapping, where we'll do just that. We'll see where the fibroids are. We'll take the measurements of the fibroids. We'll see how close they are to the uterine cavity if they're not in the uterine cavity, and then base the treatment from there. Having fibroids does not necessarily mean you can't be pregnant. Let me put that out there. That's important to know. It's just a matter of, again, where they are and how large they are.
Thank you. All right, this next one is pretty specific. This person says, my AMH was at 5.82. What do you recommend? I'm on a metformin and Clomid.
Right,
and
Clomid.
TSH is 4.76, and I'm on thyroid medication as well.
Okay, so let me take the thyroid first. So a TSH level, we want that 2.5 or less for pregnancy. Doesn't mean you can't conceive if it's not 2.5 or less. It's just a matter of that's best pregnancy outcomes. So you are correct to be on Synthroid or some sort of thyroid medicine to get that back down to less than 2.5. From the AMH standpoint, so any AMH over 4, I told you was on the higher ends of normal. And the whole PCOS, I didn't go into that, but polycystic ovary syndrome, you can't diagnose that based on an AMH level, but you can kind of get an inkling as to whether that's there. And that's why you're on the metformin. I would completely agree with that. Metformin is, for those who don't know, it's actually a diabetes drug, but it helps our bodies use insulin. And long story short, higher AMHs may need higher insulin to keep their sugars controlled, and that can affect ovulation in eggs. So metformin helps that. In regard to Clomid, that's that aggressiveness, that ladder I talked about. Clomid is a very normal oral agent that's been around for years. I will say there are some folks that are Clomid resistant, and I see it more in the higher AMHs. So you may want to try Femara. I don't know if you're ovulating on the Clomid or not, but may try Femara. You may go up that ladder and add other medications to help you recruit eggs a little bit in a more timely fashion. But what you don't want to do is add too many medications, because then you may create too many eggs and you may just increase your chance for multiples unless you're doing IVF.
All right, thank you. The next one, how long can eggs be frozen for after extraction?
Years and years. I don't know if we have a limit right now, quite honestly. Sperm also can be frozen for years, embryos as well. The technology that we have now with what's called a rapid freeze, quick freeze, whatever you want to call it, is very good. And, I told you it takes 5 to 6 eggs to maybe get 2 or 3 embryos. It used to take 10 to 12 frozen eggs. So that was only like 6, 7 years ago. So the technology is really advanced. And so they can be frozen for years.
Right, this next one says, if my husband's semen analysis came back great, just morphology was 3, will that play a big factor?
I don't think a 3% morphology is all that significant. 4% is normal. So at 3%, if all his other numbers were normal, I don't think that's greatly affecting things. That being said, I mean, if you've done a number of other evaluations and cycles, it may not hurt to simply take that empiric next step of adding the office insemination to try to overcome any potential there. But on the grand scheme of things, if everything else is normal and the only thing is the 3% morphology, I don't think that's of great clinical significance.
All right, we have a few comments, but no, let's see. Oh, here we go. Another question, will your Columbia office be set up to do retrievals and transfers?
Yeah, great question. Unfortunately, it won't be. The reason for that is the IVF procedure suite and IVF lab is a very expensive endeavor for anybody. When I was at Duke, they actually built one right before I got there, and the architect, I'll never forget this, the contractor said, this is the most expensive building I've ever done for this size. And so I say that because it's a big endeavor that we would have to grow into. So the Columbia office is going to be mainly for monitoring and potential semen analysis, IUIs, and other ultrasound evaluations. So, you know, we're doing a lot of telehealth, just like we're sitting here. 83% of our non-procedural visits are telehealth over the computer. So I have plenty of patients in Columbia. I have patients in Georgia, North Carolina, Texas. But I say that because even though you may not be here, we can still be your doctor and have the evaluation and the protocol put together. And once that Columbia office is open, we can actually just have you monitor there, because I can read the images from my computer right here where I'm sitting in Greenville, and we can plan things that way. But to get to the level of an IVF lab and procedure suite, that's a very large step, and we would have to have the volume to make that realistic. But hopefully.
All right, it looks like we've gotten through all the questions. If anyone has any more last minute questions, quickly go ahead and type those out for us. But I do want to thank everyone again for being here today with us. I know this information was really informative. Thank you again to Prisma Health for making this event possible. Let's see, there's one more question in here. Do you recommend having sex every other day after you end your menstrual cycle? Is having sex on ovulation day a big deal?
So basically how I tell, and I just had this conversation this morning, basically what I tell folks is, if you're trying to hit that window of 48 hours prior to up to the day you ovulate, obviously it's important maybe to know when you ovulate. And if you do, I tell you, if you're ovulating around day 14, let's say, of the 28-day cycle, I tell you day one of your cycle is full flow. And so I tell you to start having intercourse around day 10. And yeah, day 10, every other day for about 5 times. Not 5 times a day, every other day for a total of 5 times, because that will catch that window of when you should be ovulating. And again, you have to have intercourse before you ovulate to conceive. And so that should catch that window. So I say every other day starting around day 10 or so.
All right, I think that's all the questions. So thank you again, Dr. Likes. I know we all appreciate your time and your expertise. And thank you everyone for joining us today. We have more of these Spring into Health events coming up. So make sure you take a look at our events calendar, uofscalumni.org/events for more.
All right.
Yeah.